Everybody get yourselves in focus. We're doing the wonderful world of paniculitis. Okay, so forward. Derek, you want to start us out?
It's like a triangular punch. There's the fat. Pretty thickened septae. Some inflammatory cells, a lot of inflammatory cells, deep, very thick. This looks histiocytic.
Mitoses.
Lots of mitoses and eccentric nuclei, so somewhat plasmacytoid.
Okay.
And plasmacytoid goes with what line usually?
B cell.
Yeah, so something in a B spectrum, right? Sheets and sheets of plasmacytoid B cells with lots of mitoses and kind of monomorphous implies you're probably dealing with
Lymphoma.
yeah. So do you know any paniculitis like lymphomas?
Yeah. Just that.
And so this one with the plasmacytoid Bs, it's not particularly rimming like a subcutaneous paniculitis like T-cell lymphoma. There is maybe a little dermal involvement. Certainly there was something interface at the junction. That's something that, especially if there's karyorectic debris deep, brings up the possibility of a gamma delta lymphoma. They tend to have sub-Q dermal plus junction and karyorectic debris deep. So you're definitely going to want to walk your way through this, see how they mark. Tread carefully. Okay.
So the gamma delta is bad prognosis.
And gamma deltas tend not to have a good prognosis. That is true. And the sub-Q paniculitis like T-cell lymphoma is certainly much better.
Is gamma delta B or T, or is it only T?
Gamma delta is T, and the subcutaneous paniculitis like T-cell lymphoma is obviously T,
Okay.
but there are sub-QB lymphomas as well.
So, looks like. Looks like maybe more of there's EOs, there's infiltrate kind of deep and
Yeah, so mainly EOs and limbs, right?
superficial. So it makes me think of maybe like the eosinophilic paniculitis, since there's so many of them.
So you're definitely in an eosinophilic paniculitis spectrum. So name some causes of eosinophilic paniculitis.
Church-Strauss.
So Church-Strauss would be a big one on the vasculitic side. Deep arthropod reaction.
And then like hyper IgE.
Hyper IgE, main difference being Church-Strauss is vasculitic with EOs behaving badly, and hyper IgE, the EOs beat on your organs, but not particularly with vasculitis, just directly toxic. Anything else? What if you were fond of ceviche and had slowly migrating
Like
urticarial
helmintic.
things? Yeah, exactly. Like naphostoma, which tends to be deep. Or if you're a happy pet owner, toxicariasis, all of the worm-associated things can do it as well. Okay. How about this?
Okay, so lots of inflammation. Kind of like little nodules of it.
Yeah, so you definitely have nodules. And the nodules are what kind of infiltrate?
They look like, I think they're lumps from here.
So the black things are lymphs,
Mm-hmm.
and the gray things with no collagen between their,
More like histiocytes.
more like histiocytes, like granuloma. Okay, and then as we get down into this area here, let's find a good. And a nice example. So first off, is this more of a septal or more of a lobular paniculitis?
So right here, I think it looks a little bit more septal, actually.
Are all the circles the same size, or do you have big circles and little circles?
No, they're not. So lobular.
So you've got granuloma out in the lobule. You've got big circles and little circles, which means there's been necrosis of the fatty lobule. You have granuloma, and let's see if we can find a nice.
Looking for like a beanbag cell.
Well, so beanbag cells would go with what?
I would go with cytophagic histiocytic.
So beanbag cells would go with cytophagic histiocytic paniculitis, and is that something that ends well?
No,
No. That ends, how does that end?
a hemorrhagic.
Hemorrhagic death. You sort of hemorrhage from every orifice, which is not a very nice way to go. There's definitely fibrin in here. Not quite caseous, but sometimes it's more caseous than fibrinous. So tell me about things that cause a lobular granulomatous paniculitis with caseous or fibrinous areas.
So that'd be maybe more like Ian Doratum.
So Ian Doratum would be a big one that you don't want to miss because it is a marker for tuberculosis. So if I culture this, I grow TB out of it, right? No, because you have high immunity to the TB, which is why you have Ian Doratum, and it's very difficult to grow anything, but you often can detect it with PCR. So it's in there, it's just dead because of your high degree of immunity. So Ian Doratum would be one, connective tissue disease paniculitis, and then direct infection. So anytime you have a granulomatous paniculitis, you want AFB cultures and fungal as well as bacterial cultures. So infectious, connective tissue disease, NOS, not really lupus paniculitis, but just general connective tissue disease spectrum, and then make sure you remember erythema indoratum. What if you have clusters of neutrophils in there? Does that lead you towards anything?
Newts, I think, maybe like alpha-1 antitrypsin.
So newts, in addition to infection, you don't want to forget alpha-1 antitrypsin because of the implications for lung and liver. So let's see what else we got here.
It looks pretty lobular. We have almost radiating crystals.
You definitely have rosettes of crystals and a granulomatous paniculitis, and it's lobular. So you're thinking. Tell me about the age of the patient based on that dermis.
Probably very young.
That's kid skin, right? So you're thinking.
It's just so cute. Yeah,
Yeah.
fat necrosis of the newborn. Sorry.
So
just like-
subacute fat necrosis of the newborn, very descriptive term. What if this were adult skin and you had something that looked identical? What would you suspect?
Maybe traumatic or steroid injection,
post-steroid,
yeah.
not steroid injection, but after systemic steroid. So post-steroid fat necrosis looks very similar to subacute fat necrosis of the newborn. So look at the dermis. If the dermis is bright red, small, collagen bundles, and lots of fibroblasts, that's kid skin. And if it's adult skin, then it's less likely subacute fat necrosis of the newborn, more likely post-steroid fat necrosis. And the two both show granulomatous paniculitis with those rosettes.
Good for inflammation in the septum. It's kind of extending.
So it's definitely weighted to the septum, and the circles tend to be all similar in size and shape, right? So that it does not look like there's necrosis of the lobule. And in the septum, you have granulomatous inflammation, and within the giant cells, you have these clefts.
Measures good.
That's a Meischer's granuloma, which tends to be pretty good for what?
Erythema nodosum.
Enodosum. So acute enodosum is neutrophilic. Chronic enodosum becomes granulomatous with Meischer granulomas. In the acute phase, colchicine works beautifully for someone with really, really tender because it shuts down that whole neutrophilic process. Doesn't do much for you in the chronic phase because it's granulomatous at that point, and other drugs would be better.
Which ones?
I'm sorry?
Which drugs would you use more chronically? Which would you go to?
Well, rest, elevation, NSAIDs, and iodides can be a two-edged sword, but can be helpful. So iodides can induce neutrophilic disorders like acne, can flare sweets, can flare dermatitis herpetiformis, but can treat the more chronic stage, especially granulomatous EN. So SSKI start with 1 drop TID, rapidly go up to 20 drops TID as tolerated for nausea. If they're on it for any significant period of time, you got to check their thyroid because you will suppress it.
So you have inflammation in the dermis, nodules, maybe. And you have more of a lobular paniculitis.
And what do you have?
It's like neutrophil.
Neutrophils and caseous necrosis. So with granuloma, neutrophils, and caseous necrosis in the fat, what do you have to think of?
Ian Doratum.
So Ian Doratum, which is what this patient had. And how are you going to test for Ian Doratum?
You do a quant gold
Why don't you do a PPD?
because they get a lot of, I think they get a lot of reaction.
Yeah, I mean, I had one guy that, remember, I grew up before Quant Gold, right? So you used to do a 1,000th dilution of PPD, and we had a guy who almost had an arm amputation. The reactions are just fulminant to the PPD, which is why a Quant Gold would be just fine usually, now that we have something that doesn't put the patient at that risk. So definitely a Quant Gold with the possibility of Ian Doratum. What else?
You also just think about infections. Want to get
So infections, so you want a biopsy for culture, and then culture for anything deep and smoldering is always going to be routine AFB and fungal. And you always take it to the fungal desk because they've got to slice and dice it. Over at the routine micro, they grind it up with glass beads. You do that to a fungus and nothing's going to grow, right? So you take it to the fungal desk and they divvy it up and give everyone their bit. And what's the other thing? You said nudes, right? Alpha-1 antitrypsin. So you don't want to forget that one because the lung disease is not so nice. So and there is treatment for it now. And there's a new assay that you can get for free. We have kits.
Looks like you got some inflammation, superficial fat right in there.
Yep.
In the deep dermis. Trying to decide if it's around the vessel or anything.
So not so much around the vessel. What kind of inflammation?
Granulomatous.
Definitely granulomatous in the septum. Do you see Meischer's type clefts?
Not really.
Not so much, right? And then you look up in the dermis, and what do you have in the dermis?
Is that some necrosis?
Yeah, you got an abscess, right? Palisaded granuloma with abscess.
Infection, potentially.
So definitely infection, and if you have stellate abscess with granuloma, what kind of things do you think of?
Clats.
Which is?
Cat scratch, LGV, atypical mycobacterium, sporotrichosis, and then
and you forgot
TB
tularemia.
or tularemia.
And then you also think of tuberculosis, and this patient turned out to have TB. But definitely go through an infectious differential as well.
Looks like lobular paniculitis because of phalangism.
Yeah, and now I'm gonna flip down my condenser, and I'm gonna put my hand in there. And what's all that stuff?
Silica.
You are correct.
Wow.
So, first off, there's some crud on the slide, but you can also see that there's stuff actually in those cavities as well. And it's kind of, a ghostly shadow of something there, which is pretty good for silica. So this is sclerosing lipogranuloma or silica granuloma. The silica is rarely pure. It can be, and it's not silica, but silicone, right? So silicone, like what used to be in breast implants, a thick, viscous liquid, and sometimes they are using various lipids that they mix with it, and because it has a tendency to migrate en masse, they add sclerosants to try to scar it down in place, and then as that migrates, it's not very nice. So you will, we used to see it a lot in New York, patients who had cosmetic augmentation procedures in other parts of the world, and then would come in with massive swelling of their feet, and it all migrated from their calves. You see it breast, buttock, you see it in genitalia.
Lobular paniculitis.
And lobular paniculitis.
I've seen lumps like roaming around the visual.
Do you see any lymphs roaming around? And are those lymphs round,
Yeah, they're kind of,
or are they kind of squared off?
yeah, definitely squared off.
So hyperchromatic square lymphocytes. Does that sound like a nice benign lymphocyte?
No, it's not bad enough, but
Yeah, exactly. So that's a subacute paniculitis like T-cell lymphoma.
A lot of blood, a lot of, is that saponification in there? Got some pancreatic paniculitis.
It looks exactly like pancreatic paniculitis, and you even get, for jeopardy, since you phrased it in the form of a question, you get extra points, right? So that absolutely looks like pancreatic paniculitis with saponification and ghost cells. And so if your patient is fat female and 40 with abdominal cramping, she probably has what?
Female fat 40.
With
Oh yeah,
abdominal cramping.
stones.
Yeah, gallstones, right? And what if your patient is 65 and
An alcoholic.
was asymptomatic?
Yeah.
Cancer.
Then it's much more likely pancreatic cancer, right? And what other symptoms do they tend to have when they have pancreatic panniculitis? Ankles hurt.
Oh.
Ankle ache, because you get the same thing happening in the ankle fat pad. So that's very characteristic for pancreatic panniculitis, is your ankles are killing you. And then what's the most important look-alike that can look just like pancreatic panniculitis? Mucor.
Ooh.
Mucor in the fat can look just like pancreatic. So, and pancreatic is so characteristic that your tendency is low power pancreatic. Next case, look a little closer, because Mucor would be very relevant to patient outcomes. So, and Mucor in the fat can be a dead ringer for pancreatic panniculitis.
It's not very happy, the fats.
So what's wrong with it?
It's like gone.
It's like gone, exactly. So all the fat has been sucked out of the lipocytes. So what's your differential?
Fat sucked out of lipocytes.
Or gone from
Liposuction.
lipocytes? Well, no, liposuction removes entire lipocytes, does not remove the lipid from within the lipocyte.
Maybe some kind of injection of a fat dissolving substance. Or
And even there, you tend to get a panniculitis that resolves, like Kybella type, post-Kybella. Whereas this would be A, inflammatory panniculitis, B, lipoatrophy.
B.
Yeah, so this is lipoatrophy, which you can get from a number of things. You can get it from lipodystrophy. So this is someone who seems to have no fat anywhere on their body, and they started with diabetes at a young age, and they have hypertrichosis, and they probably have,
Like the congenital familial lipo.
which is Lawrence-Seep syndrome.
Just look at
But I lied. This is actually someone who has a partial lipodystrophy, and so if it's an acquired partial lipodystrophy, what other organ do you have to look at?
the bone marrow.
Kidney, because they get a C3 nephritogenic factor, so they're beating on their kidneys. So partial lipodystrophy goes with C3 nephritogenic factor. Congenital lipodystrophy with hyperandrogenism goes with Lawrence-Seep, with resistant diabetes, insulin-resistant diabetes from a young age. You can also see it in patients who are cachectic. They have severe lipoatrophy, just they've used up all of their stores of fat. This was someone with congenital diabetes, right? And Lawrence-Seep. You'll also hear it as Seep-Lawrence. I don't know who described it first. My guess is one or the other.
So it looks like we've got a lot of inflammation or somewhere on the eccrine coil.
And what kind of inflammation?
Lobular. Oh, sorry. Like lymphocytic.
Are these lymphocytes?
I don't think I can really tell from here. Maybe
let's go one higher.
multinucleated cells.
Yeah, like giant cells.
Like giant cells, yeah. That's what I see.
So you definitely have some granuloma there. And
then it's like lobular panniculitis.
so do you have necrosis of the lobule, or do you just have spillover of some inflammatory cells into the lobule?
Definitely looks like some of them are a few different sizes, but the way that you worded that, I'm gonna assume it's more
Yeah, I mean, this is,
subtle.
they still have delicate membranes that look intact, so it's, within the range you can see in a normal lobule. So I'm thinking more there's a lot of granuloma, which suggests we're in a chronic stage, and yet at that chronic stage I don't see a lot of fat necrosis,
Okay.
right? So I'd put it more in a septal granulomatous paniculitis, which goes with
Yeah.
enodosum. Give me some causes for enodosum.
Strep, oral contraceptive pills.
And the pill's probably overrated as a
Right.
cause, but strep, definitely. What if I'm a young female with potato nodes in my lung? And
Sarcoid.
yeah,
Is that
so
what they're called? Potato nodes.
yeah, like big. Have you never heard in radiology potato hylar potatoes?
Nope.
Okay.
That might have.
I guess I was
Maybe
taught.
Idaho.
I was taught by Germans and Irishmen, right? So the big, they look like spuds in your hilum, and that is a young woman typically, and that's Lofgren's, and she's going to have transient febrile sarcoidosis, whereas a black child with enodosum and really sore, swollen cheeks, like he's got the mumps, is more likely to be Hereford syndrome, and that's not benign, that's progressive. And so you've got someone with sarcoidosis. What organ system other than lung do you have to look at? Heart, cardiac conduction system, acute death. One of my recent fellows, her husband, young healthy guy, died of cardiac sarcoidosis, and it definitely happens. So you're suspecting sarcoidosis. One of the things is evaluation of the heart, because that's the thing that's going to kill them quickly. Lung disease is more a chronic thing. The heart disease can be, a healthy person who drops dead. So, that's something you definitely want to make sure you don't miss. And
Do you just an EKG or an echo or send them to cardiology? What's the
probably best to send to cardiology. It can show up on EKG. The important thing for us is just to make that association and make sure someone is looking at the heart, whether it's their primary care or someone is looking, and they can open a book and look at how do you evaluate cardiac sarcoidosis. His widow is heavily involved in the Sarcoidosis Foundation, and raising awareness of that, because it's not, everyone thinks of lung with sarcoidosis, and the cardiac can be devastating. Okay, so first off, what do you see up in the dermis here?
Is that more like is it like nodular?
Yeah, nodular tuft of vessels. So where do you tend to see that?
Like on the lower legs?
On
like
the lower
stasis
leg, and there's a
change?
little kind of golden brown stuff in the background, so that suggests
Like stasis change.
like stasis change. And then tell me about the fat with those
So it's
big
halfway
cavitary
lobular.
areas.
It's lobular. I would look for like lipomembranous change.
And there's, it's not really prominent. There's a little bit of frost on a window pane right here. But even without the prominent lipomembranous change, given the overlying stasis and the fat necrosis, this is likely
Lipodermatosclerosis.
lipodermatosclerosis, inverted champagne bottle leg over time, but acutely it's a really tender nodule in the leg. So acutely you may be thinking enodosum. The association with stasis change, biopsy will help. And then for management, it's intralesional steroid and an Unibut. Really takes care of what's horrible tenderness there. Okay, let's see how we're doing. think we have hit most of what we need to hit. We got a couple more here that are key, and then we'll go to potpourri. Okay, so we got no overlying skin. We have the sub-Q.
They all look relatively the same size, the fat lobules.
The fat, they do. There are some thrombi, and what I'm trying to get you to see,
Is the overlying skin dead?
the overlying skin actually has rock hard retiform necrosis. So what would you be looking for in these vessels in addition
Sounds
to
like we're gonna be
thrombi?
looking for some calcium deposits.
Yeah, exactly. So all of these have thrombi, and then out in the vessel wall, you've got a little basophilic stippling. It would really be brought out with a Boncasa stain. So you're thinking,
Oh, calciphylaxis.
and how are you going to treat? This person is going down the tubes, severe pain.
Sulfate.
So thiosulfate will help with the pain and help solubilize the calcium. What do you have to do for the clot?
I guess you could dissolve it or try to.
And how can you dissolve
heparin,
clots? TPA has been used.
TPA.
So tissue plasminogen activator has been used to dissolve the clot with improved outcomes. Thiosulfate has been used, and usually what you see with thiosulfate is a pretty rapid, over a couple of days, reduction in the pain. And then they start to heal where they were non-healing before. So your sense of smell will go out of whack with the thiosulfate, but that's not a big deal.
Like a lobular.
Lobular paniculitis, and how would you characterize it? What kind of inflammatory cells?
It's like histiocytes and racing lymphocytes.
And what are the little fragments here?
Neutrophil debris.
Yeah, so it's suppurative and granulomatous paniculitis. So tell me about suppurative and granulomatous paniculitis. What are you thinking?
Infectious, alpha-1 antitrypsin.
Yeah, so don't forget alpha-1 antitrypsin. Don't forget connective tissue disease. But infection, and you're growing out pure culture group B strep.
Tissue.
Yeah, and what are they injecting for pure culture group B strep? That's vaginal fluid. So vaginal fluid gives you pure culture group B strep. Oral and feces tend to give you really foul smelling, but you're not growing anything on aerobic culture because the anaerobes are outgrowing everything, and you're not doing anaerobic culture, right? So, those would be common things to isolate for factitial disease. Sometimes it's sterile because urine is being injected or other caustic agents. I've seen liquid plumber injected. I mean, all sorts of things. So. And polarizing for bits of silica can help because often, there is something extraneous in there that's a clue. Okay, let us jump to some potpourri. Any questions on paniculitis?
With like the sclerosing lipogranuloma,
Yep.
How do you tell that from just like a lobular paniculitis? It's just different.
Tiny
cheese.
little things.
So,
So
they'll be a lot
tiny
tinier.
little circles that were too small to be lipocytes to start with. That's a clue. And then often you'll see something in them.
And is that typically mineral oil or paraffin? I feel like I've seen two different things.
All of the above.
Okay, so it's not one specific thing.
No,
Okay.
it's people will get creative and inject all sorts of things. So pure medical grade silicone actually, it migrated, but it did very little tissue inflammatory response. It was all the sclerosins that were added to it, and then the various peanut oil, and people inject all sorts of things.
Let's see, vasculature, cornea, epidermis. It's fairly normal, maybe a little trophic in places. Then you have extravasated red blood cells.
Extravasated red blood cells, and they're around what kind of vessel?
A little capillary.
Yeah. So what would be a capillaritis with red cell extravasation?
Like Schomburg's.
Yeah.
PV.
So if there's a lot of sponge with it, then you think either of Ducus and Capilonacus pigmenting purpura or of pityriasis rosea. If it's interface with the red cell, you think of either MF or pityriasis lichenoides. And if it's chronic and annular purpuric or thumbprint or any of the various patterns of pigmenting purpura, then that's in the differential as well.
Looks like got a vascular proliferation.
And what do you think the lesion was like?
Probably had a little collar out of a scale.
Yeah, either a bump that was shaved off, or the patient is long, skinny, cylindrical, like a worm.
Probably the first one.
Probably the first one in this case. And
So
so,
probably a PG. There's some septa in there.
and it is septated, right? And you have to have fibrosepta in order to call it a PG. It's a lobular eruptive capillary hemangioma. So, very good. This is from a mole, a bothersome mole in the axilla.
Looks like a lot of cave-like, cyst-like structure. So maybe hydrocystoma.
Kind of like a hydrocystoma. It's certainly a modified apocrine type gland. So what would be that mole or that mass in the axilla that you just excised? Yeah, axillary breast. Right? So axillary breast is often familial, and these are lactiferous ducts, so they're good to recognize. And then we had a whole family kindred with functioning axillary breasts who, when they nursed, they would have to roll up towels in their armpits because they would just ooze milk from their armpits. But they took it in stride. Their grandmother showed them how to do it because she had to do it. Her mom had to do it.
Maybe like salivary gland.
It's minor salivary gland. And is it happy or unhappy?
Well, it looks like there's a little bit of inflammation. I think there might be
So-
lumps.
You have lymphs, and you have clusters of more than 50 lymphs, and you have multiple clusters of more than 50 lymphs, and you have lymphoepithelial islands. So this is probably
I don't know this all.
Sjogren's.
Oh, okay.
Right.
Yeah.
It's a pretty squared off chunk. I don't see epi. There's a big vessel down there. Fat doesn't look too happy. It looks like whatever it's doing is surrounding the fat.
And so you said surrounding the fat. So
Yeah.
the fat itself,
I mean,
particularly necrotic, or not so much?
Not as much as I would think.
And yet, what would be all of this that was between the fat?
Probably septae.
Septae,
chronic
which are
granulomatous.
like a chronic granulomatous with granulation tissue in the septi. And this is on the calf of a young woman, an expanding annular lesion. So this is probably
Like EN
like chronic EN. What do you call chronic EN that expands in an annular fashion on the calf of a young woman? Villanova's disease.
Oh, sure.
They're good at basketball too. Right? So, Villanova's disease is annular, chronic migratory, EN migrans or chronic migratory EN, Villanova's disease. You'll hear all of those. It's a young woman with a tender, slowly migrating annular lesion on the calf, typically.
And some red X's, sort of.
Some red X's, which would make you think of, especially with necrotic or neutrophil debris in it.
Like a xanthogranuloma or
Like what kind of xanthogranuloma?
a necrobiotic one.
And necrobiotic and NXG with all the red X's. So what would you want to look for? Probably paraprotein.
That's right.
It's like basal cells.
What kind?
Epidendrocystic.
Yep. So this is all pink strands in search of their blue buds, right? And yet it's still going to behave like a basal cell. So basal cells are blue, except when they're red, and the red one is infundibulocystic. Pink strands, blue buds, horn cysts. This one is recognizable even though the blue buds and horn cysts aren't there. So, well done. Skip that one.
Alright, so there's kind of this irregular acanthosis. It kind of looks like there's like the vertical collagen, maybe like an LSC.
But it's definitely a bump, right?
So
And where do you think this bump is, given the small adnexal structures and prominent sebaceous glands?
like on the face.
On the face, perhaps even the nose. And you have these plump fibroblasts, some of them stellate, and a lot of this fibrosis is both perivascular and periadnexal.
It's more angiofibroma.
Angiofibroma, fibrous papule of the nose. Very good.
So a lot of almost basaloid islands, kind of pinkish.
Happy centers or necrotic centers?
Maybe necrotic centers, unhappy centers.
So suggests that this is a nice friendly thing.
We're dealing with some sort of malignant thing.
Yeah, so definitely malignancy. And then what kind of malignancy?
Perhaps an acanthocarcinoma.
Excuse me.
A porocarcinoma have this?
That's exactly where I am, is probably porocarcinoma. It's nested intraepidermally like an ugly hydrocanthoma simplex, and it doesn't palisade, and it has comedonecrosis. And what's the outcome for porocarcinoma? Is it a nice thing to have? No, it is not a nice thing to have. Airline travel, yet another bug.
Small punch. Acanthosis. Irregular. Looks like some extravasated red blood cells. Perivascular lymphocytes.
Perivascular, periadnexal, somewhat of a vertical orientation there. Some pigment incontinence below the epidermis.
Like a lupus.
Lupus, absolutely. And so now, is that squame arising in lupus, or is that hypertrophic lupus? Any way to tell? Because that can be tricky sometimes.
Looks like there's the collagen looks a little looser around it. I don't know if that would be helpful in that area.
Plus minus, but anyone what's staying with CD123. So if it's still inflammatory, either hypertrophic LE or a hypertrophic LP, there are a ton of CD123 cells all around it. They disappear when it becomes squame. So that's really helpful to differentiate. And it really can be tricky, where you may have to do that to help differentiate. And the squames that arise in there are, they're not friendly squames. They're very, very nasty squames, so you really want to know.
So you have inflammation in the papillary dermis.
And
Around the vessel.
yeah, superficial and deep around the vessels. Why is there so much space between the collagen bundles?
The collagen, probably mucin deposition.
So what do you think?
Probably more like connective tissue lupus.
What kind of lupus? I don't see any interface.
I think you can still have both on it.
Yeah, so probably like
But like
tumid.
Probably like DM. Okay. Or
Tumid lupus,
Okay.
right? So tumid lupus, you don't have the interface change, but you got a lot of dermal mucin. Used to be called plaque-like mucinosis. Chest and back, young Latin female is kind of the typical presentation. Melts with hydroxychloroquine. So, very, that's essentially diagnostic is the response to hydroxychloroquine.
A lot of inflammation at the junction here. It looks like a myxogranulomatous and potentially, or is that a halo?
You tell me.
Halo. I'd say.
It's a halo nevus, and that's exactly what you typically do. Is you say there's a lot of inflammation, and then there are cells in there that look a little epithelioid, so maybe it's granulomatous, except some are nested, and just that mixed pattern, the way they're just intimately mixed all through, is halo nevus pattern. Very good.
Looks like cardiac.
And big adnexal structures or small adnexal structures? Lots of small adnexal structures and a core of cartilage from a cheek.
Yeah.
Like right here. Yeah, accessory tragus.
Oh.
Very good. How are we doing time-wise? We're still doing
Good.
okay.
Now there's nests up there. Maybe like a melanocytic.
There are nests like a melanocytic, and towards the base of the tumor, the nests are parallel to one another and parallel to the
peak
surface.
pattern.
So this is
Probably melanoma.
melanoma, absolutely.
Okay, a little shave.
Not my fault, I just read them.
Is that just a little like wordy D or?
Like little looks, there's definitely acantholytic dyskeratosis, so if it was solitary, it could be a warty D. But this person actually has kind of brownish red crusty papules all over the V of his chest, and it's Darius.
Looks a little sebby. Those are kind of amphiphilic. Well, I think it's been melanocytic nests.
Yeah, melanocytic nests. So it's
Like a melanoma rising in a seb.
or just a nevus. You know, nevi often have seb-like features. They have horn cysts, so on dermoscopy, the presence of horn cysts does not tell you that it's not melanocytic, right? That's a double negative, but nevi commonly have seb-like features, right? And then there's something else going on, right? There's some necrosis in here, and definite necrosis within this nevus. And let's see if we can find, there's a lot of vasculitis, right? So you've got nevus with vasculitis right in the middle. And let's see if we can go to scan. See if we find something helpful. Right in here. See these little multinucleated cells?
Sure.
And try to imagine, if you will, that the chromatin's kind of out towards the edge of those cells. And you have sebaceous necrosis and vasculitis, multinucleation, molding, margination of chromatin.
Hepatic.
So, yeah. So this is zoster in a nevus. It's a three-fer. Tell me about the cells themselves.
Kind of bluish.
Small
a little
blue.
bit. I guess I'm wondering about like a Merkel cell.
That's exactly what it is a Merkel cell. You want any stains?
I don't know. If you already think it's a Merkel cell, do you need stains?
Well, because it could be small cell lung that's metastatic. So we usually get a TTF, right, and get something like a chromogranin, synaptophysin, keratin 20.
So here it almost looks a little bit squammy. Really abnormal.
Do you see any atypia?
Yes.
And what would you say the morphology of these cells is? Kind of long and skinny?
Yeah. Kind of like, I can't think of the words. Spindled.
Spindled. And tell me about their relationship with the epidermis.
They're kind of like coming out of it or slamming up against it.
So they're slammed up against the epidermis. Give me a differential for this atypical spindle cell proliferation slammed against the epidermis.
SCC, loma, sarc, AFX, and melanoma.
So you want some stains?
Yes. Like an S100.
S100's negative.
Okay. How about some keratin?
Keratin's negative.
Okay. Desmond.
Desmond's negative,
Bimenta.
positive,
So maybe
like most of God's children. CD10 positive, procollagen positive. So probably AFX. Although there are new keratins coming out, new high molecular, and a lot of AFXs are now squamous because they always were squamous.
Lots of nodules of cells.
What kind of cells?
Looks maybe histiocytic from this.
Yeah. Do you see collagen between them, or is it just cytoplasm up against cytoplasm forming a nodule?
So just granulomas.
Granulomas, and are they particularly dressed, or are they more naked?
They're pretty naked.
They're pretty naked.
Sarcoid, other naked granulomas
So
also.
sarcoid and other naked granulomas. So tell me about other naked granulomas.
You could have Crohn's, silica, granulomatous cheilitis.
Zirconium, beryllium.
Yeah.
So tell me about silica. So say we polarize this and it's full of silica. What's that? That's still sarcoidosis, right? So silica granuloma, the silica is just a nidus. Who, show of hands, who here has not skinned their knee when they were little? You all have silica in your skin. Who gets the granulomas? People with a tendency for sarcoid. So silica granuloma, they all get followed for sarcoidosis.
Let's look at hyperkeratosis.
Yep.
Underlying acanthosis. Good.
Hyperkeratosis, acanthosis. So what is it?
Porokeratosis.
It is porokeratosis. Center poro can look like anything, right? So you look for the quadrigomelia and the...
They have a nodule encapsulated. Cystic areas within.
So if all of these round things represented ducts, what would you be dealing with?
Like a dermal ductus.
Yeah, or, big hydranoma, right? Something in the acrospiromal group. But what if that's just where you have keratinization, because you see kind of keratinized cells in the middle? And so this is kind of a rolls and scrolls type complex nodule.
Okay, well, no, it's not telling me trauma, but the pilar, yeah, pilar.
Yeah, proliferating pilar. Very good.
So you got something going on at the junction there.
What's going on at the junction?
There's a lot of tagging, it looks like.
Lots of tagging. And is it normal to have this kind of linear ropey collagen in your papillary dermis?
No.
So you said lots of tagging and linear ropey collagen in your papillary dermis. What are you looking at?
MF.
MF. Great. Superficial shave. And tell me about your keratin. Is it intact or is it falling apart?
Falling apart.
What do you call a falling apart keratin? Clinically?
Scale.
Scale. And, very good. And most scale is
Yeah.
parakeratotic. This is not parakeratotic. This is a falling apart, not parakeratotic. So what's going to be there?
TV.
what's tinea versicolor, right? So that's your furfuraceous scale. So a falling apart, non-parakeratotic corneum, you look for tinea versicolor. Right. Furfuraceous scale is your only non-parakeratotic scale, and I think we're there. Well done.